Hi, so today we'll talk about multiple sclerosis, a chronic inflammatory demyelinating condition which causes damage to nerves. Now we'll see a hypothetical picture of the brain and a lesion in the white matter. The white matter is basically a collection of axons, whilst the nerves make up the grey matter of the brain. Now we see the axons of the nerves and we see that they are covered by myelin. Myelin is supplied by the oligodendrocytes which covers about 2 to 3 nerves at a time. And we can see the presence of inflammatory cells, which will eventually cause demyelination and damage to the oligodendrocytes. Um, so, it causes damage to the oligodendrocytes, and we have some particular features that we see on histology. Oligodendrocyte loss. We could also see axonal degeneration, which will account for the neurologic symptoms. And also see reactive astrogliosis. It means the glial cells, the astrocytes, will proliferate in the area of the lesion. And by the time this appears grossly, we're going to see it as that lesion in the white matter, usually when we do an MRI. Moving on to the causes. Causes could be genetic or environmental. It's usually an interplay of genetic and environmental factors. And some scientists have attributed viral infections and the reduction in the amount of vitamin D. Um, Now let's take a close look at a vessel in the brain, say the blood-brain barrier. Usually there is an increase in the expression of artificial molecules, and you have macrophages and lymphocytes and other inflammatory cells attaching to the wall and elucidating inflammation. There's also some particular molecules that are important that are looking 12, which is pro-inflammatory, B7 and there's a decrease in the amount of regulatory T lymphocytes. And there's damage to the blood vessels, and these cells move out, they get to neurons, cause lots of damage and demyelination and axonal loss, as seen in the earlier video. Now let's move on to the features we can see. Let's start from head to toe. And as you can see, starting from the head, usually, or the brain, apart from seeing the lesions there, they usually have cognitive decline. They could also have depression, euphoria, and some other psychological problems. Moving to the eyes, they have optic neuritis, they have nystagmus, and to the nose, they'll have loss of smell. They also have facial nerve problems, which will present as Bell's palsy, facial weakness, also deafness. They could also have paresthesia and dysthesia, abnormal sensation, and alongside other symptoms really. It manifests generally. And moving to the bladder bowel, it causes bladder bowel dysfunction and erectile problems with sexual intercourse. Other things that could be seen, um, if it affects the cerebellum, you see something called the Charcot triad, where the patients have nystagmus, they have intention tremors, and they have scanning speech. This is a pictorial representation of what Charcot triad is supposed to look like. So in nystagmus, you have scanning speech problems and intention tremors. Also, because optic neuritis, now the optic nerve and its sheath are inflamed, and because the extraocular muscles, which are responsible for moving the eye, are attached to the optic nerve sheath, movement of the eye, which will cause contractions of the extraocular muscles, will stretch the optic nerve sheath and cause pain. So usually in them, whenever they move their eye, they feel pain. They also have problems in vision because of the optic neuritis. Now let's take a brief look at the patterns. There's a pattern where they are affected and then there's a stable stage, they're affected again, and it goes stable. So basically, it remits, there's a remission period and there's a relapse period. This is actually the commonest type. We call it relapsing remitting, and it affects about 80% of them. Usually, you have good periods interspersed with poor periods. And then the second type, you have is secondary progressive, where there's an increase in the amount of worsening symptoms and a reduction in the amount of stable periods. Usually, people from that relapse and remit move towards the secondary progressive type, usually about half of them. And then there's a third type, which is primary actually, called it primary progressive, where they just start manifesting symptoms with few periods of remission and it keeps getting worse and worse.